this is just a current scenario. The National Joint Registry of England and Wales in 2023 reported that 9.5% of the hips were done as bilateral. For the knees, the figure is 16%, and this increase has occurred from 0.6% to nearly 10% in about 6 years. And like I said, this is not a new concept. John Charnley did publish a series in 1970 on 50 simultaneous bilateral total hips, and he concluded that the complication risk was slightly higher, but advantage was single anesthesia, shorter hospital stay and shorter rehabilitation period. So in 90s, the HSS, from 20 bilateral in a year increased it to 70 per year, and that popularized it. Merrill Ritter, with whom I identify because he is the guy who did multiple joint replacements in the single sitting, he published in Core in 1980 saying that the advancements such as hypotensive anesthesia and thromboembolic prophylaxis dramatically reduced complications, and it made it possible to do bilateral hip replacements at the same sitting. Then these are the reports from JBJS in 2008 and 2009, which established that it is a cost efficient procedure with similar mortality rate equivalent to unilateral. There are longer hospital stays for a single surgery but shorter when you compare with the two surgeries, higher blood transfusion rates, same complication rates, and no effect of ASA grading on complication or perioperative mortality. And this has also been the controversy in the book published, controversy on orthopedic surgery of the lower limb. Now there is a clear advantage. The hospital stay is down by 27%, average length of stay is 5 days, hospital cost is down by 28%, shorter disability period, and total exposure to anesthesia is less. Clear disadvantages are none. No study, however, included ASA grade 4 patients, so you have to be taking into account ASA grade 1 to 3. And this is a paper which we published in JBJS, and the same work was awarded the best research by Dr. Chitranjan Ranawat in ROC meeting. The only question he had in that meeting when he awarded this prize was, so you do it by posterior approach, so you do one side, then you make the patient straight, and again reposition and redrape. So I said, no sir, we do one more thing in between. That when we make the patient supine, we take an X-ray to see that everything which we have done on one side is good, and then we go on to the other side. This paper was presented by my junior colleague and a very dear student, Amitya Pankaj, because he got the check, but then we were the co-authors, and this was published in JBJS, where we showed that there is an advantage of doing both at the same sitting. There are some debatable aspects. Some people believe there is a greater risk of pulmonary embolism, myocardial infarction, renal failure, chest infection, and in-hospital death. However, the younger patients who are less than 60 with Charlson comorbidity index 0, the results are the same. And then of course, if you have a high volume unit, the complications are low. There are papers who have shown, like one on your right, that similar 90-day mortality, dislocation, PGI rates and blood transfusion, they give rise to lesser incidence of DVT, less pulmonary complications, systemic complication, local complication. But if you have staged them, then there are lower pulmonary embolism rates. This is a paper we published in JACS, and we showed that the clear indication for a bilateral total hip replacement at the same sitting is bilateral flexion contracture, bilateral ankylosis, severe limb length discrepancies, young patients, and again the Charlson comorbidity index 0. And this was a paper we published long time back in Journal of Arthroplasty. This was actually in 2008. And we had 92 patients, 38 of them were bilateral with bony ankylosis. And in bony ankylosis, like if you operate one side, you can't make them sit, you can't make them walk, they remain disabled. And what this paper did was, we did cementless and showed that it works. In this paper, we had to do additional procedures like adductor tenotomy, knee contracture release, ankle contracture release, soft tissue releases. So many times these patients had simultaneous bilateral knee flexion, hip flexion deformity. So we replaced both their hips and the knee contracture release on both the knees. And then we decided, if the knee is arthritic, why not do all together? So this was the first case in the world for a 4 joint replacement in a single sitting. Before that, Merrill Ritter had a series where he did 4 joints, but he did 2 at a time. So 2 hips and then 2 knees. And we have done that in another 6 patients after that. And this was published once we had a sufficient follow-up. This is not 10 years out. Now, what about the range of motion and functional improvement? The simultaneous bilateral total hip replacement has better range of motions and better functional improvement. The hip flexion in both hips improves the activities of daily living by allowing the patient to sit, and it improves the spinopelvic parameters. And then flexion range of motion is much more important to the patient than abduction for the functional reasons. So people have evaluated balance and gait. So unilateral total hip in bilateral disease gives rise to poor static balance up to 3 years, and there's an increased risk of falls. If you do simultaneous bilateral versus unilateral total hip in a unilateral disease, they get similar mobility, pain and fear of movement, but the bilateral had more symmetrical standing weight distribution. Cemented or cemented, there has not been shown to be any difference, though theoretically cemented can increase embolic load. It doesn't matter we are using a short stem or a standard stem, though difference at 5 years. And then the surgical approach, it can be direct anterior, posterior lateral, or like Mrinal said, anterolateral. But I believe DAA is ideally suited for single stage, because that one question from Dr. Ranawat where he said that you have to finish one, close and turn the patient over for a posterior approach, set me thinking how we can do it without wasting that time. So that was one of the key reasons for me to switch on to the direct anterior. And then we have done that, it's particularly for young ladies who need cosmetic hip replacement, bilateral, done by bikini incision in the same sitting. They are engineer, one is a doctor and one is a dancer. Better implant positioning, because obviously if you are using direct anterior, you can make sure that your component position is very good. And then of course, because it causes less pain and better scores and better gait pattern, so DA further adds to all the advantages of the bilateral at the single stage. Then the next thing which we did was to do both simultaneously, because we did one and then went on to other. The next thing we did was to have 2 teams, both which are adept at doing direct anterior approach. So we could actually do the direct hip replacement, direct anterior bilateral hip replacement in under 1 hour using 2 teams, which you can see in progress here. So obviously this is a good thing to for Indian patients. So to summarize, bilateral simultaneous THR saves time, saves money, early rehab and easier to maintain offsets. The caution is about patient selection and approach selection, but we believe that the direct anterior approach is ideally suited for the bilateral hip replacement. Thank you very much for your attention.